Thank you very much. I'm going to discuss with you complications that may occur in complicated 𝗔𝗂𝗏s, 𝗔𝗂𝗏s, 𝗕𝗏𝗏s, but they can also occur in standard 𝗔𝗏𝗏s. So I want to keep it basic, because basic is what you need. And a good quality, that means that we have to deal with our complications. And in order to be able to do that, we have to know the complications that may occur, we have to recognize them, and we have to appreciate them and take care of them. And most of the problems are actually preventable. So in my opinion, if you have a very thorough preparation of your case that you are going to do on the desk, then you will have it much easier in the OR. So the complications that may occur during the perioperative phase is either access problems, deployment problems. You might perforate a vessel, or your stent graft might occlude. So if you have an access problems and you cannot pass the iliacs with your standard wire, then you should change it to a Terumo glide wire, because that is easier to introduce. And don't forget to use the multipurpose catheter in order to get the right angle. If that doesn't help, then you should pull back your sheath, and you should suspect that you have a dissection, and maybe you have to do a puncture. And please, no fighting with the vessel. You have to treat them as they were your mother-in-law. If you have introduced your wire, but you cannot come up with your system, then if you have a preloaded system, you have to take that out, and you can use a dilator that is somewhat smaller in order to enlarge the vessel. If that doesn't help, do an angioplasty and place a stent graft, this so-called crack and pave technique. Now, this mostly happens in the iliac arteries. Either you have a stenosis where the takeoff of the external and the hypogastrics are, or you have it up in the aortic bifurcation. In the aortic bifurcation, it's normally not a big deal, but be careful because the hypogastric artery goes off in the basement, so to speak. It goes down, and it's a high risk that you might rip off the artery if you use too much force. So for the deployment, I cannot discuss all the 12, 15 stent grafts that are available on the market, but you have to go through the deployment of the system that you are going to use. You have to take it apart, or a dummy take apart, and then you should check whether if there are any bailouts. So now let us come to the placement. And the most fear that we have by a standard EVAR is that we place our stent graft too high, and then we cover the renals. Now there are some options to try to solve that. One is that you pull down the stent graft by using a Terumo glide wire, a crossover, and then you pull in both groins, and that might displace the stent graft a couple of millimeters, maybe close to 1 centimeter, but not anymore. Then you will strip the aorta, and you will have a spaghetti aorta instead. So then, if that does not work, you have to cannulate the arteries and place a stent. And if that shouldn't work, then of course you need to do a conversion. Here, an example of a patient receiving a stent graft with a suprarenal fixation. On the left side, you can see that it is a little bit too low, because this is where you have the markers for the fabric. And on the right side, it is a little bit too high, but still it was deployed at this level, and even though this angio would indicate that both renals are open, this is a dangerous situation, and that is because the fabric starts very high up here. So you have covered more than 2/3 of the left renal artery. And in this case, I would, like we did, cannulate the artery. And here you can see that it's the catheter is hanging on the fabric. And then you place a stent, and then you have solved the problem. Now another case with difficulties in cannulating the target vessel. This was a fenestrated stent graft for a thoracoabdominal aortic aneurysm. We had done the planning, and then we received the stent graft, and everything looked fine. All the orifices were at the calculated place. And then we introduced the fenestrated stent graft, and we deployed it. But as you can appreciate here, there is a rotation, and there is a stenosis of the right renal artery. And the rotation in combination with this stenosis made it not possible to get into the renal artery. And this projection, it looked as was it possible, but then see it in an AP view, we were just in the aneurysm as well. So then the question was what to do. Then we said, why don't we try to mobilize the stent graft away from the wall, from the outside? And then we did that, and it was possible to cannulate the right renal artery. So then we introduced a sheath into the right renal artery in order to dilate the stenosis, and then through the fenestration it was possible to come in with a wire, and then we pulled back the sheath from below, and then it was possible to cannulate the right renal artery and then place a stent there with a good end result. So sometimes you have to think a little bit outside of the box. If we go down to the hypogastrics, if you have covered the hypogastric artery, you might try to push up the stent graft a bit. I find it very hard. You cannot do it with a balloon because the balloon will press the stent graft towards the wall and fixate the stent graft, so to speak. So easier would be then to cannulate from below and then place a stent graft like I showed for the renal artery, but coming from below. One thing is to recognize though, and that is that only 1/4 of the patients will have claudication after they have a covered hypogastric artery. So don't put too much dangerous effort in trying to revascularize the hypogastric artery. If you have placed your contralateral limb at the place where it looks good, and it's outside of the stent graft, so you don't have it inside, but you have it outside, then it is not possible to cannulate and to get it into the small limb. So then you have to convert to an aorta unilac by blocking the short limb and then do a crossover. Endoleaks we have discussed a bit. If you have type 1 endoleak, you can try with PTA, cuff, maybe a palmar stent or a proximal extension. If you have type 3s, you can do that with a PTA or a new lining. The type 2s and type 4s and maybe type 5s, in the OR, leave them alone. Many of them will resolve during follow-up. Perforation, if you have a proximal perforation by a balloon, by doing the molding, then open conversion is most likely the way to go, because if you are not familiar with chimneys, to do them in acute phase is not possible. Do I get a minute? Yes, okay. Whereas if you have a distal perforation of the iliacs, that's easier to deal with. If you have an occlusion, do a thrombectomy with a means that you are familiar with. Do a PTA and a stent. It's normally a kink of the stent graft system that causes the occlusion. And for the control angiography, please pull out all the stiff wires in order to demask any kinks that would appear. If you have a post-operative problem with an increased creatinine, I think that you should always check that the renal arteries are patent without any stenosis, and then think about colonic ischemia and also about limb ischemia. And with that, thank you for your attention.